Well, welcome again. Thank you so much for taking the time out of your Monday to join us for today's webinar, Promoting Shared Decision Making in PCOS Management. I'm Katie Schubert. I'm President and CEO of the Society for Women's Health Research, and we are a national nonprofit dedicated to advancing women's health through science, policy, and education while promoting research on sex differences to optimize women's health. And we are absolutely pleased today to have two distinguished panelists joining us for our event. Dr. Anuja Dokras, Professor of Obstetrics and Gynecology and Executive Director of the Women's Health Center for Clinical Innovation and the Director of the PCOS Center at the University of Pennsylvania School of Medicine. And Dr. Ali Chappell, Registered Dietitian and Chief Executive Officer of Lilly Health and a PCOS patient and advocate. I'd also like to thank the sponsor of today's event, Abbott, and note that SWHR maintains independence and editorial control over our program development, content, and work products. And as always, we are live tweeting during this event, and we invite you to use the hashtag SWHR Talks PCOS on all social media channels. Please join that conversation. So with that, at this time, I'd like to introduce SWHR's Chief Science Officer, Dr. Irene Aninye, who is moderating today's event. Irene.
Thank you, Katie, and welcome everyone. Polycystic ovary syndrome, or PCOS, is a condition that is characterized by an imbalance in hormone levels, specifically an increase in level of androgens. Typically, one or more eggs are released every month during a woman's menstrual cycle, which is known as ovulation. In women with PCOS, eggs do not fully mature, and many remain in the ovaries surrounded by small fluid-filled sacs or cysts. The high androgen levels have also been associated with interfering in the development and release of these eggs. PCOS affects between 8 and 13% of reproductive age women worldwide and nearly 5 million women in the United States. Some common symptoms associated with PCOS include irregular menstrual cycles, very heavy, or very light periods, weight gain, acne, and excessive hair growth. And because of its role in interrupting ovulation, PCOS is considered one of the leading causes of infertility. It's important to note that everyone will not experience the same presentation or severity of symptoms. In fact, PCOS is defined as a clinical syndrome and does not require the presence of ovarian cysts for a diagnosis. Limited awareness and education about PCOS among both patients and providers contributes to the nearly 70% of women with PCOS going undiagnosed. These women have an increased risk of developing serious health conditions, including diabetes, cardiovascular disease, anxiety, and depression. It's imperative that women are supported by an interdisciplinary care team that works together to effectively manage their uterine health and overall health well-being. Today, we have two experts who will share their professional and personal expertise as we engage this important discussion. Following the speaker presentations, I will be moderating a discussion with both of our panelists, so we invite you to use the Q&A function to submit questions throughout the event. We'll try to address as many questions as we can during the program, focusing on submissions that cover recurrent themes or questions with broader applicability to the audience. So I'll now introduce Dr. Anuja Dokras as she turns her camera on to talk about diagnosing and managing PCOS care. Thank you for joining us.
Thank you, Irene, and it's great to be here and be part of this webinar for the Society of Women's Health and Research. Let me go ahead and share my screen. Here are my disclosures. And what I wanted to start off first with is reminding everybody that we've been making the diagnosis of PCOS based on what's called the Rotterdam criteria for the last 20 odd years. So in 2003, these criteria were described, and it includes first what you see there as the irregular periods. But there are a number of different conditions that can make periods irregular. And so the doctor really needs to make sure that they rule out thyroid problems, problems from other glands in the brain, like the pituitary hormones, prolactin, as well as the follicle stimulating hormone. The second criteria is either biochemical or blood levels of the androgens being elevated, as you heard in the introduction, or clinical, where there can be excessive hair growth or acne. And again, it's a diagnosis of exclusion. So certain blood tests need to be checked to make sure there are no other conditions mimicking or causing the excessive hair growth. And then the third criteria is polycystic appearing ovaries on ultrasound. And that word polycystic is a misnomer. It's actually increased number of follicles within the ovaries. And more recently, I'm going to talk about that in a second, we added anti-Mullerian hormone as the third criteria. So based on these Rotterdam criteria, PCOS is the most common endocrine condition in reproductive age women. So that's pretty powerful because, you know, it's more common than thyroid problems, more common than diabetes. And last year, there's an international group of experts who got together and have updated the international PCOS guidelines. So the first time these guidelines were written was in 2018. They endorsed the Rotterdam criteria. And then in 2023, when we updated this, we added AMH or anti-Mullerian hormone within that third criteria. So now one could essentially take a nice detailed history from a patient and just do blood work and may not even need an ultrasound in order to establish this diagnosis. So moving on from the diagnostic criteria, I did want to, in today's talk, especially because we're talking about shared decision-making, share with you one of our sort of pivotal studies that we conducted in 2017. And one of the questions in this survey that we asked patients was, how long did it take for your diagnosis to be established? And though majority of them were established within like the first 6 months, a third of them said that it took more than 2 years. And that's really astonishing, both in North America and Europe, given different healthcare systems, we got a similar response. And then again, we asked, what was the number of healthcare professionals you saw before the diagnosis was established? And though the majority had seen just 1 or 2, there were quite a few who were seeing 3, 4, or 5 providers before this diagnosis is established. And you also heard that there's a large proportion that go undiagnosed. So significant patient frustration. And then to get to the bottom of this, we also surveyed physicians to try to understand physician knowledge regarding PCOS. And the two groups here are the specialists, the reproductive endocrinologists in the dark blue, and the general OBGYN in the light blue. And we found that a higher proportion, about a third of general OBGYNs did not know the exact diagnostic criteria that they were using. And hence we identified a significant gap. And that's when the international guidelines were established. It's been 5 years since they've been updated. And we do hope we're in a much better space now. When we surveyed trainees, right, the new doctors who are being trained, we found that only 10% of the residents identified the Rotterdam criteria. So really what we've identified is that there's significant gaps in knowledge. We need to increase awareness about this condition, not only amongst our patients, but the educational institutions, so that there's more importance given in terms of covering topics like PCOS. So this is just a shout out to the International Guideline Development Team, where they have looked at a number of areas in addition to diagnoses in terms of screening, models of care delivery. And what's even more important is that we've had engagement from a number of medical societies across the world, in addition to a number of patient support groups, both from the US, the UK, as well as Australia. So this has been a phenomenal effort in the PCOS space. So to sort of conclude this part of my talk, you know, we are now here with the established Rotterdam criteria that we use, and it's 2 out of these 3. And in adolescence, because that's when the diagnosis sometimes, the presentation sometimes is more obvious, it's only 2, the first and the second, and we don't use the ultrasound or the AMH criteria as yet. So once the diagnosis, let me talk a little bit about AMH just briefly, that this is a blood test. It's a hormone that's made by these little follicles, the small antral, preantral follicles, and the granulosa cells within it make the AMH, and that's why the AMH levels are high in women with PCOS. And AMH plays a role in the irregular periods or the lack of ovulation because it inhibits the action of FSH to a certain extent, or at least decreases its sensitivity. So when you heard that in the introduction that the patients do not ovulate every month, AMH is responsible for some of those actions. So once the diagnosis has been established, we need to start thinking about this not just as a gynecologic condition, but as a chronic lifelong condition which has reproductive issues, could have cardiometabolic issues, as well as psychological issues. And again, in the interest of time, I'm not going to go over details in each of these categories, and we can talk about them during the Q&A. But the first thing sort of I do want to say in terms of fertility and fertility outcomes, this is a really nice study that comes to us from Sweden, where they looked at over 45,000 women with PCOS, and they followed them for over 26 years. And what they found is, look at the line in red, that's patients with PCOS, and then the blue is control. A fair number of them get pregnant on their own. These are spontaneous conceptions. So PCOS is not associated with lack of getting pregnant. A number of patients can get pregnant, but it's a lower success rate, as we see here. And then what we find is once they receive help with pregnancy, the overlap is great. So the treatments are fairly successful. So this is very reassuring to share with our patients. What we really need to focus on right now, though, is how do we make this pregnancy healthy and safe? And so we do know that women and patients with PCOS have a higher risk of obesity, diabetes, impaired glucose tolerance, and metabolic syndrome. And that can then reflect in pregnancy with a higher risk of pregnancy-induced hypertension, preeclampsia, gestational diabetes, and preterm delivery. And even once they deliver, our group has shown that there's a higher risk of preeclampsia in the postpartum period or eclampsia in the postpartum period, blood clots, and other conditions. So it's a high-risk pregnancy, and our role is to try and make the pregnancy as healthy as possible by focusing and optimizing on preconception health. So this is a very nice algorithm from the guidelines that really tells us to improve the health of our patients prior to helping them with pregnancy. And the options for pregnancy or fertility management are oral medications, those that can be taken by mouth, like letrozole and clomiphene. Very few need to go all the way to IVF. And then going on to the metabolic issues associated with PCOS. So I already mentioned that a higher risk of obesity, diabetes, impaired glucose tolerance, and metabolic syndrome. Not everybody is going to have these complications, but we do see them even at a young age. So it's not just age dependent, and hence one needs to screen even patients who are in their 20s and 30s. We see the higher risk in those who have high male hormone levels. So the hyperandrogenic phenotype has a higher risk. So again, not all comers, but here are certain subgroups that are at high risk. And we found certain ethnic variations as well. You might say, okay, if there's a higher risk of some of these cardiometabolic risk factors, do these patients truly have a higher risk of stroke or myocardial infarction or ischemic heart disease? And the answer now is yes. So a number of studies show us that there's an increased risk of all of these cardiovascular events. And as a result of this data, we have now included in the guidelines that PCOS actually is a cardiovascular disease risk-enhancing condition. And so what does that mean? What do we need to do as physicians, and what should patients expect? That there will be metabolic risk assessment with their visits, and the risk assessment includes assessing the weight and the BMI, assessing their glucose tolerance, and depending on their family history, or if it's done in pregnancy or not, the schedule and the frequency can change. A blood pressure check at every visit is recommended, And now the new recommendation that came up in the more recent guidelines was cholesterol or lipid screening, at least at diagnosis, because of that long-term risk of cardiovascular disease. There is some suggestion that there may be increased risk of obstructive sleep apnea, as well as fatty liver disease, increased risk of endometrial cancer as well. We took away the excessive screening, and so are not recommending checking insulin levels at each visit anymore. And then the third category is the mental health risk, and there is a higher prevalence of depression. I'll show you the data for that, but also negative body image, low self-esteem, and disordered eating. So here is data again from our group showing a high prevalence of depressive symptoms and anxiety symptoms in young women with PCOS. And this has informed the guidelines such that we are recommending screening for both depression and anxiety right at the time of diagnosis and with the first visit. So let me sort of end here with saying that the approach to PCOS needs to be lifelong, and the focus should not be just on reproductive or gynecologic issues, but cardiometabolic as well as mental health issues. And as you see over here, the models of care delivery can include a multidisciplinary approach, because the gynecologist may address the irregular periods, the risk of hyperplasia, infertility. One might need to see a dermatologist for excessive hair growth, acne, or a psychologist for the mental health issues. In pregnancy, we do recognize this as a high-risk condition, and again, a long-term risk of cardiovascular disease. So thank you again for including PCOS in the SWHR webinar series. I want to just give a big shout out to all my collaborators and partners, especially at the Penn PCOS Center, which who have all contributed to my journey in the PCOS world. And I'm going to end here, and at the end, we'll be happy to take any questions. Thank you again.
Thank you so much, Dr. Dokras. Please note for those that are tuning in that you can submit questions at any time using the Q&A function, and we will try to address as many as we can during the panel discussion portion of the event. Next, we'll have Dr. Ali Chappell, who will share about her PCOS diagnosis journey and how she continues to navigate her patient experience. Thank you, Ali. Welcome.
Can you see my screen?
No, not yet.
Okay. Okay. Let me see.
Yes.
Okay. Well, thank you so much. I'm very excited to be here. Good morning, everyone. My name is Ali Chappell. I am a PCOS patient myself and PCOS patient advocate. I'm also the CEO and founder of Lily Health, which is a digital technology company for women with PCOS. And today I'm going to talk just a little bit about my personal journey with PCOS, but also things I've learned along the way and to help really advocate and help empower patients to advocate for themselves. So my symptoms started at the age of 14. And so I've been managing PCOS for 24 years. I'll let you do the math. And really my symptoms started with weight gain. I started gaining weight. I had severe acne. I was on Accutane twice in high school, which is pretty significant. I didn't start my period until I was 16. And after that, I had one period every 6 to 12 months. So when I would visit my pediatrician, they would schedule an ultrasound. And every year, they'd say, you have irregular or you have cysts on your ovaries, but it's okay. It's normal. And I would go about the next year, and every year this happened for probably 6 years. I went through various healthcare providers. I went to college, still had severe acne, still struggling with my weight, and I also had severe anxiety and eating disordered issues. And so finally, at the age of 21, I visited the on-campus health clinic, and I was diagnosed with PCOS by a women's health nurse practitioner. At that point, she said, you have PCOS and you're going to need to watch your weight. Here's some birth control pills and a brochure, and sent me on my way. Now, at this point, I was studying to be a dietitian, And I was getting ready to graduate that year. And I'd never heard of PCOS, not in my whole 4 years of nutrition education. And I'd never understood and never even learned about insulin resistance, to be honest. And I was confused about how my weight or my diet could affect my ovaries. And so that really led to a journey where I had to understand and learn about insulin and insulin resistance as with PCOS and how nutrition was really wrapped up into that. And so I went and pursued a master's degree, thinking I would learn all that I needed to know about PCOS. And not once did I learn anything about PCOS during a master's degree in nutrition. I became a dietitian. I never learned one thing about my diet, about PCOS in a dietetic internship. I never saw a PCOS patient, and I never had one question on that PCOS exam to be a dietitian. And so this really says what I will talk about on the next slide. It's exactly what Dr. Dokra said, is that there is a lack of understanding about these conditions among healthcare providers. So I pursued a PhD in reproductive endocrinology because I really needed to understand the reproductive hormone part of this to match with what I knew about the metabolic dysfunction underlying. And this led to about 13 years of research in nutrition, insulin resistance, and PCOS. So first is, what are some of the gaps in care that are leading to so much of frustration for these patients? So on my journey, I was lucky to receive a National Science Foundation grant to help me launch Lilly Health. And in part of that, I had to interview hundreds of patients and healthcare providers all over the world to understand whether the patient journey in the US was the same in other countries, whether the provider treatment was the same in other countries. And I really identified 4 areas where there's a gap. Number one is that there's a discomfort among providers with diagnosis and treatment. First is that, of course, dietitians, they don't learn a lot about PCOS in their nutrition education, and I knew that firsthand. But even with some healthcare providers, I remember specifically, I interviewed an OBGYN in the US, and she'd been a provider for 40 years, 40. And I asked her how comfortable she was with the diagnosis and treatment of PCOS, and she said only somewhat comfortable. And I think this highlights an important gap among healthcare providers because many patients don't have access to a reproductive endocrinologist who truly understands PCOS. They either see pediatricians or family medicine providers, but rarely, or OBGYNs. And many times these providers aren't fully comfortable with diagnosis and treatment. And the other part is the metabolic dysfunction. Few healthcare providers get true nutrition and metabolic information during their training programs. And so understanding the metabolic dysfunction underlying is also a big gap in care. So many times, just like Dr. Dokra said, these patients jump from provider to provider without fully understanding their condition. And this is the same journey in all corners of the world. Second is lack of effective treatment options. There's a handful of options that patients can take, but many of these have some side effects that patients don't tolerate. And also they don't get to the root of the issue, which is really insulin resistance. The third is absence of clear lifestyle guidance. Lifestyle change is first and foremost the most important thing when it comes to managing PCOS. And this is not something I was ever educated on in my PCOS journey. And I think many patients can say the same thing. When I was diagnosed, I had my blood levels tested. My androgens were very high. All of my metabolic labs were completely normal. But my insulin levels and insulin resistance was so high that it was actually throwing my thyroid off. And I was diagnosed with hypothyroid and put on Synthroid. So all of the treatment was put on thyroid medication. So all of the treatment options that were provided to me weren't really getting to the root of the problem, which was really the fact that I had insulin resistance. And the other thing is that there's so much conflicting information. You have some providers that are on different channels providing different information, which really may not be exactly what is important to focus on when it comes to the treatment of PCOS, which is really around lifestyle. It's not about taking a million supplements. It's not about going on crazy diets. It's really understanding your metabolism and how it differs from other patients and what you can do about it. So last and most importantly is how to advocate for yourself on this journey. First and foremost, want to remind you that just because something is common doesn't mean it's normal. I think for every time I had an ultrasound that I was told that you have cysts on your ovaries, but it's okay, it's normal. Just because something is common doesn't mean it's normal. And patients need to be explained, why do you have cysts on your ovaries? Why are you skipping or missing your period? Why do you have severe acne? Just giving birth control pills or just giving some sort of a medication doesn't get to the root cause of why you're experiencing those in the first place. So number one, effective communication. Prepare questions before your appointments. Ask your providers. And if they don't seem to know the answers, or they're looking it up on Google while you're sitting in front of them, seek a second, third, fourth, fifth, sixth opinion. Find somebody who truly understands PCOS, because again, it's not commonly taught in medical training, and it's not commonly taught in nutrition programs. Keep detailed health records. Track your cycle. Track your symptoms. Make sure that you're coming to the table prepared with what you're experiencing if you're trying to either get a diagnosis or you're trying to find effective treatment. And then third, build a support system. When I was diagnosed, there were no smartphones. We didn't have Instagram. We didn't have really this ability to go and find all this conflicting information or to find support groups. So find a support group. Make sure your family fully understands what you're going through, and so that they can help support you and create a supportive environment. So this is definitely, my experience, my personal and professional experience, and then also just helping you and empowering you to advocate for yourself on this journey and knowing that you are not alone. Thank you.
Thank you so much, Dr. Chappell. And I invite you both to bring your cameras on at this time. As we're pinning again for attendees that are here live, we invite you to submit your questions using the Q&A function within the webinar app, and we'll try to address as many as we can in the next 10 to 12 minutes. And please note that our conversation today is intended for educational purposes and is not intended or implied to serve as a substitute for medical or professional advice. We encourage all patients and consumers to confirm information and consult their healthcare provider to determine their individual needs. And so with that, let's open up this conversation. A couple questions have actually came in about monitoring hormones and progesterone, estrogen, AMH that you mentioned. And so how important is it to monitor progesterone and estrogen, or even AMH, to diagnose and treat PCOS?
Yeah, that's a very important question, and it comes up a lot of times. So in terms of diagnoses, the estrogen and progesterone levels are not useful. It's really knowing that the patient has irregular periods is sufficient. And as you heard from Ali, if you keep a good calendar, and most of our patients these days will open up their phone and have an app and really be able to very precisely tell us, last year or in the first 6 months of this year, I got 2 periods or I got 3 periods, and for how many days. And that is sufficient for your doctor or provider to use as your first criteria. The hormone that needs to be evaluated are the male hormone levels, so not estrogen and progesterone, but the male hormone levels, either the total or the free testosterone, and that would give the second criteria, whether those are elevated. They're never in a male range. They're only slightly above the female range, and the male range is several fold, like 4 to 10-fold above a female range. And so just that slight shift is enough to make the periods irregular, give the hirsutism, acne. And then the third hormone now that has been validated and introduced in the diagnostic panel is AMH, or anti-Mullerian hormone. So those are sort of for the diagnoses. None of this needs to be monitored on a regular basis long-term, because now your diagnosis is established. And so a repeat AMH may only be collected in terms of counseling for fertility, if that comes up along your journey. A repeat male hormone level may only be indicated if the hair growth isn't getting better or the acne are getting worse, even when you're on treatment. But otherwise, there's no real recommendation to be measuring these on a very regular basis.
Thank you. And so, you mentioned, Allie, that from time, it was when you were young. And what are some of those hallmarks? Is there an age that you found is helpful? Because it was your normal, right? Like you were now used to this. What kind of alerted and what advice would you give to young women or women in general when it comes to how to understand whether or not their normal is actually normal for them, or their usual might not be normal or okay?
Well, I do think, like Dr. Doka said, just because you have cysts early on, right after you begin your period, sometimes that isn't abnormal. Sometimes many women have, or many young patients have cysts on their ovaries. But I knew it wasn't normal when I was only having one period a year. When I was asked when my last period was, and I couldn't remember, it was sometime last year, that's not normal. But I that became my normal, never having a period. And I thought, this is great. I don't ever have a period. And I never really considered it to be a problem, because I wasn't old enough to really understand that that was a problem. And then when I was 21 and realizing, okay, mostly for selfish reasons, I wanted to know when I was going to get a period. I didn't want to be going on vacation and think, oh, all of a sudden I'm having my yearly period right now. I wanted it to be more regular. And so that's when I went in and I had the ultrasound. So I would say that I never really knew that I was abnormal. I knew that I was probably had more disordered eating than people I knew. I knew that I probably had more anxiety. I knew that I was the heaviest one in any of my nutrition classes. And despite working hard, I knew that that wasn't normal. It couldn't be normal. But I never knew that they were all interrelated until I really did my own research.
Irene, can I chime in with that?
Sure.
I totally, we see this so often, the same story that Ali presented. It's hard in adolescence or when you go through puberty to get an accurate diagnosis because, as we all know, it takes a year or two for those periods to get regular. And so that could be a challenge initially. And, one might say this is fine and it's normal. But I think saying the next thing is, please track your periods. And if they don't get more regular over the next, whatever, 1, 2, 3 years, depending on when the patient presents to you, that I think is what's missing. It may be totally fine because it's the first year and you got one period. But what's not fine is if it's your third year from puberty and menarche and you're still getting just one period. I think that's where the gap might be, is in trying to, and it may get better now because I think the younger generation is very savvy with tracking their periods, staying on top of it. And there has been a lot more education with the pediatric medical societies as well, because they're the ones who are going to see the patients with the young presentation.
Right. And I think also when it was with acne, it's pretty rare to have somebody on Accutane twice and then still get acne after they come off of it. Accutane is pretty effective in most people, but Accutane Proactive, nothing worked for me until I changed my diet. And that was really the only thing that worked long-term. And I think that that's fine, seeing my friends and family members on Accutane and then completely come off with beautiful skin, and I still had acne. I knew there was something not normal about that too.
Yeah, and then Ali, the other thing you mentioned, which we should just clarify for the audience, is getting the ultrasound and talking about cysts. So we have struggled a lot with this word polycystic ovary syndrome, which we all inherited from years ago, right? So this was first described in 1935 is when PCOS was described. In the interest of time, I showed the picture of the two gynecologists on the screen, but at that time, they did surgeries and they found patients with huge ovaries and large cysts. Nowadays, what we see on the ultrasound are tiny follicles, those preantral follicles, and a count over 20 gives us the diagnosis of PCO-looking ovaries. But there are follicles in them, and each has an egg. They're not cysts which are going to rupture or cause pain. So we don't have the ultrasound in the third diagnostic criteria at all anymore, because it's very confusing. When you're young, you have a lot of follicles because you have good fertility and good ovarian reserve. And so that third criteria is only applicable in adults. And doing that ultrasound or now the AMH level is more relevant. And you, instead of getting the patient anxious and worried, and telling them they may have cysts, I think we are really trying to educate physicians and providers to come away from using that third criteria too prematurely and restricting it more to the adult population.
Not really transition, but you both kind of touched on it with the normal presentation and how it's been described before. And a lot of times you hear PCOS, of course, it's associated with infertility, but then there's this conversation about you have to lose weight. Lose weight, lose weight, lose weight, and your symptoms will go away. Lose weight and your fertility will improve. Can you speak to this recommendation and how it, the potential stigma associated with this weight management as opposed to like lifestyle management and other ways to manage PCOS as opposed to you just have to lose weight?
I can help you. So when it comes to weight, there's just a direct correlation or even causation between weight and insulin resistance, which then goes on to affecting your testosterone levels. And that testosterone or those androgens are really what are affecting your cycle and all of these symptoms. And so it's not necessarily that weight is having anything to do with it. It's the insulin resistance that's related to that. But you can absolutely take steps to start reducing or helping reverse that insulin resistance completely independent of weight that will then help you lower those androgens. I can say, personal stories that I probably didn't lose all the weight I needed to before my symptoms started improving. And so that's important to show that just weight loss alone is not going to be the answer. But I did have to make lifestyle changes from things that I thought were healthy because they weren't healthy for me. They weren't good choices for my metabolism. And when I started avoiding those or started limiting them or being conscious about my consumption, my acne improved, my menstrual cycles improved. So I wouldn't say that it was necessarily about weight for me. It was out making intentional lifestyle changes that really made all the difference for me. So I hope that makes sense on my end. And I'm sure Dr. Dokris sees a lot of these patients too, that just small lifestyle factors is all that it really takes to achieve whatever goals it is that you have for PCOS.
Yeah, you're absolutely right. So the first line treatment for this syndrome at large is lifestyle management. And lifestyle management, as we all know, is sort of a combination of the dietary choices, but exercise. And the goal here is twofold. One is there's a tendency to gain weight with PCOS. And with the higher androgens, there's a tendency for this weight to be gained more in the middle of the body or the abdomen kind of region. So we want to prevent weight gain as one of the goals because the increased risk of cardiometabolic complications. So if you can at least maintain the weight and then have the smaller, incremental decrease, that's going to be critical. But we want to also come away from the weight stigma because, as you saw, the three sort of pillars of PCOS also include a psychological impact, and that comes with the intense focus on body image, hair growth, and weight as well. So I think the question was really spot on that, it's not as much weight loss, but it's lifestyle management. And the reason being it has to be lifelong because of all these other complications associated with PCOS. But we do see that in a large proportion of patients, weight loss is associated with the menses becoming more regular, the male hormones might drop, and then, of course, the cholesterol, the lipid, the insulin levels will get better as well.
And I'll add just one thing too. And sorry, I keep adding. Is that weight is a symptom of insulin resistance, not the other way around. And so if you can target the insulin resistance and reverse that, all of these other symptoms will start to improve. And your weight may not change drastically immediately. It may, stay stable, but all of these other things, because it's the insulin resistance that's affecting the weight, but it's also affecting the mental health. It's affecting the reproductive health. It's affecting the metabolic health. So that's really where the intentional effort needs to be placed, not just, I'm going to try to lose weight, I'm going to eat less calories, I'm going to exercise more, because that's not being intentional about what is actually the underlying problem. And so that's why I say take weight out of the picture, because weight is just a symptom. Focus on the insulin resistance, because that's really where the problem is.
Point, you're having these conversations, right? You're trying your treatment regimen. You say, let's try this. It may or may not be working. Let's make these adjustments. And there's this concept that we always say it, shared decision making, right? We talk about shared decision making, but it's very clinical, right? But for an individual who's going into the doctor's office, the doctor will never say, or the healthcare provider will never say, we're going to do shared decision making, right? Like they're not going to say it by name. So how can a woman know that she's being engaged in this process when it's happening? Like, what are some of the key features of a consultation where I can recognize, okay, I'm actually having shared decision making? And how is that different from like maybe informed consent? It's like I tell you everything, you make the decision, or I make my recommendation, then you do it. What's the difference there?
I think shared decision making is so critical in a heterogeneous condition like PCOS. Like at least the things I put on my slide, not every patient is going to have all three diagnostic criteria. They may have any of the two, right? So they may have very regular periods, but then they'll have the other two boxes they check off. Or they may have no high elevation in the androgens and just the first and the third criteria. So one size doesn't fit all. And because one size doesn't fit all, it's shared decision making, right? We need to really manage the symptoms that the patient comes with and the complaints that they are coming with. Whatever their complaint is what's bothering them most. Sometimes some hirsutism or acne may not bother someone. And we're not going to prescribe things to improve that if that's not the concern. If the concern is their long-term or metabolic health, and that's the focus, then that's where I think the shared decision-making and management needs to be targeted. Now, of course, there are some aspects of PCOS that definitely need to be managed. For example, the 1 period a year that you heard from Ali. And the reason for that is an increased risk of either hyperplasia or cancer within the lining of the uterus. So that becomes more of you are at an increased risk if you don't get more frequent periods, and we need to help you manage that. Whereas some of the other presentations might be a preference from a patient perspective, and that would be sort of, you could lay out the options and the palette of these are the options that are available, and then we could either address them one at a time or sequentially or all together or prioritize them.
And I would just say that patients need to not feel so scared to ask questions. They really need to ask questions. Sadly, I've seen this movement on social media about birth control pills. They're absolutely evil. They're causing PCOS, or their birth control pills are prescribed often for patients because they're not having a period. And they need to have something that's going to help them shed that lining so that they can prevent endometrial cancer. So sometimes it might be that the doctor doesn't fully understand PCOS. They don't know how to answer the questions, but they know they need to prescribe these birth control pills to help them have that shed of that lining. That doesn't necessarily mean that they're ignoring the patient or just brushing them off. It's that they're trying to do the best they can to prevent a very important chronic condition that they could be experiencing. So I think if providers were explaining, hey, this is why I'm prescribing birth control pills, I'm not just ignoring you and your symptoms, I'm doing this to help protect you, I think it would provide a lot more understanding of the patients as to what the role birth control pills have in PCOS. But I think more of that, understanding what are the medications that I'm being prescribed and why are they being prescribed to me. For dietitians, if you're asking me, or if you're giving me these recommendations and I'm following and I'm not finding success, why am I not finding success and what could I do differently? So I think more so it's just making sure you're coming to these conversations prepared to ask questions, challenge your healthcare providers.
So what I'm hearing is being able to communicate, definitely coming in prepared. You talked about the apps or just logging and tracking your menstrual cycles and your periods, but not just your periods, but the symptoms associated. If I can add to that, there are, you know, back in the day, there were calendars, you have a journal, there's apps, there's online spaces, but essentially having that information so that when you're in your appointment with your provider, you're able to communicate a little bit better without having to do so much memory recall. And then I'm seeing, I'm hearing this idea of definitely make sure you have the questions and you get the information that you need. And so this has been a really great conversation. I thank you so much for joining us. I want to ask one last wrap up question for you guys. We often have patients and healthcare providers. We also have researchers, policy professionals that tune in to webinars like this. And so what is one takeaway that each of you would recommend to our viewers to help support women in their journey with PCOS? And so we'll start with Dr. Dokras, and then Allie, just your 30-second, here's the hill that you want to land on.
Yeah, what I'm going to say is, we've put in a lot of work in developing international guidelines for PCOS. And so if all of you can, and I can put it in the chat, but I just did the Google, if you do a Google search for just PCOS guidelines, it pops up. In there is a very provider-friendly handouts, which are not as onerous as the 243 different recommendations. And also for patients, there are 5 just 1 page each patient-friendly handouts on each topic. It's all free. You can download it and use that. So I would definitely encourage everybody to log in. And if I have a minute, I can even put it in the chat.
And for me, it would be understand insulin resistance and understand how nutrition influences or reverses insulin resistance. It took me a long time to understand that certain foods can be healthy, but they may not be the best choice for my metabolism, because the reality is that PCOS, we're a different breed and we have a different metabolism, and it requires a very individualized and intentional approach. And that is something that I've done research on the last 13 years. And I have tons of free education and free pamphlets and free downloads and patient education materials that you can find on my website, as well as all of my research.
Thank you so much for both of you. Thank you for your time and your insight and the transparency with you shared your expertise with us today. Also like to thank Abbott for their support of this event and SWHR's PCOS program. To all of you out there, be sure to connect with SWHR on our website, www.swhr.org, as well as on social media to register for future events and sign up for our newsletter. You can download women's health resources like our Exploring PCOS Throughout the Body poster that talks about how PCOS can impact heart, mental, and reproductive health, and provides tips to empower women to prosper in their uterine health journey. We will be sending out an email with the recording of today's webinar to all registrants, as well as post the recording on the event's webpage for future viewing. So please be on the lookout for that and feel free to share with others as we continue the conversation. #SWHR Talks PCOS. Thank you for joining us.
Thank you.